Getting sick shouldn't mean getting broke, but for millions of Americans, it does. Hello everyone, I'm Samyukta Dahal, and in this presentation, I'll break down how medical debt fuels healthcare inequality and why it demands our attention right now. Today, I'll focus specifically on medical debt and its impact on access to care. This issue affects not just the uninsured, but also low income individuals who do have insurance. As healthcare costs continue to rise, the burden on ordinary Americans grows heavier. This isn't just a personal finance problem, but it's a critical public health and economic issue that demands our attention. My central argument is this: medical debt actively increases healthcare inequality in America. I'll demonstrate this through four key points. First, medical debt limits access to necessary care. Second, it causes severe financial instability. Third, it disproportionately harms vulnerable population. And finally, it reveals deep structural problems in our healthcare system that require systematic solutions. Let's begin with how medical debt affects access to healthcare. Research from Lopez and Kearney shows that people routinely delay or skip medical care simply because they cannot afford it. This isn't just inconvenient, it leads to measurably worse health outcomes, as documented by Doughty and colleagues. When people avoid doctors until emergencies strike, costs explode and health deteriorates. These financial consequences extend beyond medical bills. Studies by Hamilton and his team found that medical team is a leading cause of bankruptcy in America. Meanwhile, the Federal Reserve reports that medical bills create crossing financial stress that ripples through families for years. Second, the medical bill creates widespread financial instability. It damages credit scores, drains savings, and forces impossible choices between paying for households, food, and medicine. Third, vulnerable populations bears the heaviest burden. According to the Census Bureau, low-income communities and minority groups are disproportionately affected. The Centers for Medical and Medicaid Services confirm this population face the highest healthcare costs relative to their income. This isn't just an American problem. Research by Tikkanen and Avrans showed similar inequality patterns globally, suggesting systematic flaws in how healthcare is financed worldwide. Fourth, these patterns reveal structural problems in our healthcare system. Medical debt isn't an unfortunate side effect, but it's a symptom of deeper issues: fragmented insurance coverage, opaque pricing, and a profit driven model that prioritizes revenue over patient well being. So, what can we do? The solution require bold action. We must expand insurance coverage to eliminate gaps where people fall through. The American Hospital Association and CMS both emphasize the urgent need to reduce actual healthcare costs, not just shift who pays them. Price transparency, administrative simplification, and public option insurance could all help address the crisis. My analysis draws on peer-reviewed research, government data from the Federal Reserve and Census Bureau, and institutional reports from the American Hospital Association and CMS. These sources provide rigorous evidence for the scope and severity of medical debt in America. As I conclude, I want to invite reflection on several questions that I have considered in my research. Is my thesis that medical debt increases healthcare inequality clear and compelling? Do I have sufficient sources to support each claim? What aspects of my argument need strengthening? Are my points convincing enough to move someone from awareness to action? And finally, what perspective or evidence might I be missing? I believe medical debt represents a moral and policy failure we can no longer ignore. The question isn't whether we can afford to fix it, it's whether we can afford not to. Thank you.